Okay, we're going to go ahead and start with the musculoskeletal and neurological assessment. Okay, I was checking, making sure it was working. Okay, this is the musculoskeletal and neurological assessment. This will serve as the lecture for Unit 7 or for 8 and 9. We'll just start out here. These are the objectives for these 2 units. Okay, this is the video from Builder-Back Hill, and we're not going to watch it right now, but I'll post a link on Blackboard and we can watch this in lab, and then you can watch it on your own, but it's a little lengthy and there's no need to watch it all during the podcast. Okay, the musculoskeletal system, it's going to consist of 3 main parts: muscles, bones, and joints. Muscles are, we know what muscles are. This is a review from your anatomy class. We're not going to go back and look at all of that, so you need to be responsible for that. All of this is needed for support, movement, protection, and the production of red blood cells, storage for essential minerals. When we're thinking about the musculoskeletal system, we're thinking about falls, different things that happen with the musculoskeletal system, which it can be falls or anything of the sort. Let's see here. Okay. I'm going to go back a slide here. When we're starting out our assessment, musculoskeletal assessment, we're going to start with just a general observation of the client. And this needs to start when they first walk into the room, because I'm going to start off here with the gait. This is going to be one of the first things that we assess with the client, is going to be their gait. And when you walk into somebody or walk up to somebody, or you're assessing them, say, walk across the room for me, I'm going to assess your gait. If there's something abnormal with their gait, they're going to try to fix it, even if it's just subconsciously. So we want to look at their gait when they're walking in the room. We're going to watch how they stand. We just need to systematically assess the whole body and how it works from head to toe, proximal to distal. We're wanting to look at the base of support. Is it as wide as the shoulders? What is the foot placement? Is it smooth, even, well balanced, or do they have like a stagger? Any associated movements? Their arm swings should be opposite and equal. And we're going to look for, we're going to start out when we're talking about the gait. They could have some abnormal gaits. And abnormal gaits are going to be the next slide. That's going to be an unusual or uncontrollable walking pattern, usually caused by disease or an injury. So a propulsive gait, what this is going to be is they're stooped over, kind of bent over, rigid posture, kind of a cardinal sign of advanced Parkinson's. They've got a bit of the kyphosis, which is the rounded back. And it's not really as much kyphosis, it's just they are kind of where they're stooped and rigid. Scissor gait is adduction of the thighs with each step, causing the knees to hit or cross in a scissor-like movement. It results from bilateral spastic paresis. Then we have a spastic gait, and that's going to be stiff. The foot drags, foot dragging walk, and it's caused by unilateral muscle hypertonicity. And then steppage gait is going to be from foot drop, and that's usually caused by some kind of lower motor neuron problem, disease there, which causes the outward rotation of the hip and exaggerated flexion of the knee. Toes hit the ground first, producing an audible slap. And then the waddling gait is distinctive, kind of duck-like. It results from deterioration of the pelvic girdle muscle. Sometimes you'll see kids start with like a waddling gait. Okay, their stance. When we're looking at somebody's stance, we want to look at them and just basically how they're standing, like we talked about before. We want to look and see, do they look symmetrical? Do they look like they're leaning to one side or the other? What's the width of the legs? Are they standing with a very wide width, or do they look almost military stance, which could be completely normal for that person. If somebody has had an extensive amount of military training or something like that, or police training, they'll just automatically stand like that. Are they steady? Do they have any assistive devices? Do they have a cane? Do they have a walker? Are they holding on to the wall? Anything of that sort. Okay, their posture. So here's a picture. Normal is going to be comfortably erect, and that's what we'll call it. So we're looking for straight lines. We're looking across the body parts. So see this middle one here? We've got it goes straight down. Okay, poor posture. You'll see this one a lot of times. Okay, poor posture. The head's more forward. The back is flatter, and it's not very flattering. You could say that. And then here's another form of poor posture, and the head's kind of forward and the shoulders are round. Your abdominal muscles are really weak. So just see how the difference there in that posture makes a difference in how that person looks. Okay, we have lordosis, and this is a picture of it. So lordosis is the exaggerated lumbar curve. So the patient's going to have, if they have pronounced lordosis, the lumbar spine is abnormally concave, as shown in the picture. Lordosis, as well as the waddling gait, is normal in pregnant women and young children. So you will see this with them. Kyphosis, that's going to be a curving of the spine that causes a bowing of the back. It's going to lead to more of the hunchback or slouching posture. The thoracic curve is abnormally rounded, and you can see that in the picture right there. Scoliosis. I don't know if you all remember, but I remember with scoliosis being checked in school. They would take you in the in gym class in the locker room, and they would check you for scoliosis. You would bend over, and they would use a device and run down your spine to see if there's any curvature there. It's always away from the middle or sideways. They'll have uneven shoulder blade height and shoulder blade prominence, unequal distance between the arms and the body, asymmetrical waistline, uneven hip height. This is what you'll see with somebody with scoliosis. So when you're assessing your patient for this, you're really just going to, you can see in this picture, the curvature is going away right there. There's some difference in the shoulder blades, and the hip height is also a little different. Okay, when we're talking about examination of joints, we're going to start with inspection like we do anything else. And you're looking for size and contour, redness, atrophy, any deformities, any swelling. The different joints we're going to assess we're going to start with the TMJ, the temporomandibular joint. And we've assessed this with when we did HENT, and you're just going to assess that the same way. You're going to put the tips of your index fingers in front of the middle of each ear, and you're going to ask them to open and close their mouth. They should be able to open and close and protract and retract the mandible easily with no pain or tenderness. The fingertips should drop into the depressed area over the joints. If there's like a click sound, suspect an improperly aligned joint. Swelling of the area, crepitus, or pain might occur with that. With the joints, so what we know about joints, and I've kind of skipped this, is it's the junction of two or more bones. Okay, so we have two different types. We have non-synovial and synovial joints. Okay, and then the popular joints that we're going to see are going to be ball and socket joints. So that's going to be like your shoulders and your hips. Flexion, extension, adduction, and abduction should be done with those. They need to rotate in their sockets. They're assessed with the degree of the internal and external rotation. Then we have hinge joints, and that's like the knee and the elbow. Okay. When we're palpating any of these joints for that tenderness, if it feels thicker in that area. And it's always good to palpate one side against the other. We're not going to go down and do head to toe the right side of the body and then head to toe the left side of the body. We want to palpate the left elbow when we're palpating the right elbow, because you'll be able to really compare those two there. Okay? And this talks about the joints. I've talked about the temporomandibular joint, then your elbow, your shoulder. There's a lot that goes into these joints. And there's a lot of pain that can be associated. A lot of things can happen. Okay. Okay. When we test the range of motion, we need to demonstrate how they're going to go through normal range of motion. And then we're going to have them move it that way. And then we're going to compare that bilaterally. You're also going to do it against resistance. See if they can do it against resistance. Right here, older adult considerations. It's going to reduce flexibility, decrease muscle strength because of age-related muscle fiber, joint degeneration, reduced elasticity of the tendons, and joint capsule calcification. Okay, this is something you need to make sure you know. The rate didn't mean to do that. The rate the muscle strength is with this strength table. Okay, this is very important to know the different ratings and what it should rate. A normal strength classification, active motion against full resistance, is a 5. Okay, range of motion. So we need full mobility of each joint, deliberate, accurate, smooth, and coordinated, no involuntary movement. When you're doing your focused assessment on this, and when we're doing our head-to-toe assessment, anytime you do this, you need to know the proper names for things. Not, I'm going to make them pull their arm in, or I want you, or demonstrating it. You need to know the proper terminology for this, okay? We have retraction and protraction, so you'll do that with like the TMJ joint, and that's moving it back and forward. Abduction, which I'm skipping ahead a little bit here. I think I've got a whole thing on that abduction, so we'll keep going. Okay, muscle atrophy. Here's a good picture of muscle atrophy, and you'll see this. And this is just when it's not been utilized. When we are, if something's, it's a true term. If you don't use it, you lose it. So atrophy is also called muscle wasting, and it's gonna be from prolonged muscle disuse. Some muscle atrophy occurs with aging, and you'll kind of notice this. Okay, subluxation. That's going to be a partial or incomplete dislocation of the shoulder. You can see how that works there. Okay. and this is the shoulder, and this is pretty much what it'll look like. I used to love putting shoulders back in when I was working in the ER. It was a very, I guess it was a tedious thing to try to get them to go back in. And then there's some people that put their shoulders out on purpose, but most people, it's a very painful procedure and they don't like it. But it's tedious, and it really makes you work trying to get that shoulder back in. Okay, a contracture is going to be fixed tightening of muscles or tendons, ligaments or skin, shortening of longest or strongest muscles. I'm sure you've seen some of the patients that were in the long-term care facilities, or some of your patients who've been bedbound for a long time. They have some contractures, okay? It's gonna, once this happens, it's gonna prevent normal movement of the associated body part. They're not gonna have the range of motion. The skin might become scarred and non-elastic and limit the range of motion in the affected areas as well. You'll see this a lot with the feet. You'll see almost like a permanent foot drop with people. Okay. I'm done with the slides for that, but we're going to talk about a little bit more. There's one thing I really want you to review, and that's going to be a Prezi that I post on Blackboard. It's going to give you a lot more information about some of the range of motion, your joint motion. It's very in-depth. I've done the presentation before, but it's really just as good if you can review it. We need to make sure that we know the different types of range of motion and what the proper terminology is for those. With the hands, with the fingers, with everything that you're going to run into. When we're looking at the muscles, we do need to look at all the muscle groups. Look for the symmetry. Does it look atrophied? Is there any hypertrophy there? You can measure them and compare them. There'll be a slight difference in the measurement. Okay. And then, of course, you're going to document your findings. Let's see here. A good way that we might want to document something like this is, we've assessed a patient and we'll just talk about their full range of motion in upper extremities. It's going to be strong, bilateral, hand grip possibly. If there's weakness, maybe weakness in the right leg and it's gone unchanged since the last assessment, what the muscle strength is, 3 out of 5 maybe, and then the left leg will be 5 out of 5. That's just a way that you'll document it. But now for your focused assessment, you do need to tell us exactly what abduction is. Abduction is going to be when you're taking something away from the body. Okay, so just think abduct, Amber Alert. A child's been abducted. They've been taken away. So it's being taken away from your body. Adduction is it's added to your body. So it's going to move more toward the midline of your body. Flexion, bending, it's going to decrease that joint angle. It's going to actually decrease the joint angle. Okay? You can see it right here. So this angle, and then we're decreasing it to like a 90-degree angle right there. Okay, and then extension is going to be straightening or increasing the joint angle. Circumduction is moving it in a circular manner. Okay, we've got internal rotation right here. So that's going to be turning toward the midline. External rotation is turning away from the midline. And then you'll have pronation, so that's turning downward like the hand. It would be palm down. Supination is going to be turning the palm upward. Eversion, like over the feet, eversion would be turning it outward. Inversion would be turning it inward. Seeing if I find any other notes here that before we move on. Make sure that you actually do your abduction and adduction to the fingers as well. You'll have a radial deviation and ulnar deviation. Okay, they're going to rotate the wrist and by moving the entire hand, first laterally, then medially. Okay, kind of like wax on, wax off. Okay, I'm going to be Karate Kid here. Wax on, wax off. But that's really, follow what your book says about these assessments, and we're going to do this in lab as well, but this is just the small amount of lecture that goes with the musculoskeletal. Okay, neurologic system. When we're assessing somebody's neurologic system, we're going to start out just like any other assessment. We're going to just, by looking at them, what's their general appearance look like? Are they appropriately dressed? Are they well groomed? Is there an odor that you notice? Do they make eye contact with you? What does their posture look like? We talked about posture a few minutes ago. So what does that posture look like? It's kind of long. For a proper neurological assessment, it's going to be kind of long. You're not going to perform it all the time in its entirety, but in the initial screenings, you're going to do the entire thing. You want a detailed assessment. Because if we don't have a proper baseline, then we don't know what to base anything off of. Okay? And just because you did it, and you know that patient may have talked and had proper speech with no slurring before they went to surgery, but you're off for 4 days, or you're going on vacation and you didn't document that, they come out of surgery and nobody knows if that person had slurring before. And maybe they had a stroke while they were under anesthesia and it goes undetected because it wasn't charted. It's kind of a worst case scenario, but that could easily happen. And this is also the Builder Back Health video, and we'll watch that in lab as well. It's 25 minutes long, so we're not going to watch it part of the podcast. Okay, we're going to check their orientation. So, person, place, time. They can be oriented. Can they be oriented and still confused? Yes, they can be. Orientation to time is going to be normally the one that's going to be disrupted first. To person is going to be last. Okay? When we can ask what their name is, what their mother's name is. That's going to be orientation to another person. What the year is. Sometimes you could ask me what the date is, and I'm not going to have any clue. I can roundabout tell you, but I'm not going to know exactly what date it is. How old are you? We're going to ask that. That's going to talk about memory. Where were you born? That's a remote memory. What did you have for breakfast? That's recent memory. Okay. Who's the president? Okay. That's going to offer some general knowledge. Can you count backwards from 20 to 1? And that's going to be attention span and calculation skills. Don't ever come at me and ask me if I can say my ABCs backwards, because I certainly cannot do that. I can probably get like Z, Y, X, and that's about the extent of it. So, and you have to take your patient into consideration there too. Okay, level of consciousness, a little more on that. Response to environmental stimuli. Are they awake and alert? And they're going to follow command, respond appropriately. That's what that's going to mean, okay? Are they lethargic? Lethargic, stuporous, comatose, coma. So, lethargic, let's talk about it first. Lethargic is going to be they're drowsy, has delayed response to verbal stimuli, okay? Stuporous. Stuporous is going to require vigorous stimulation for a response. Sometimes you'll have to do sternal rubs for somebody who is stuporous, okay? And that's when you take your knuckles and you rub along the sternum. It's painful stimuli, just to sometimes get them out of that stupor, okay? And then we have comatose. So they're not going to respond appropriately to verbal or painful stimuli. If they're not fully alert, you might need to increase whatever stimulus you got going on. Note any changes in the level of consciousness. Use variety in the questions you ask. Just like I mentioned on the slide before, we're not going to just say who am I, where are you at, what's today's date, and then just take it from that. Now we can ask them more questions. We can ask them, what's your mother's name? What's your father's name? What's the year? Where are you at? Where were you at before you were here? What's your address? Things of that sort. Okay. Give them 1 or 2 part commands. We can do the mini mental status exam. I'll post this on Blackboard. Okay, it's going to be widely used. It's a good screening tool to evaluate cognitive impairment. It's going to measure briefly the orientation to time, place, immediate recall, verbal memory, calculation, language, and constructability. Each area tested has a designated point value with a max of 30 out of 30. When you complete this, the score achieved is going to be a clearly recorded summary that we can always refer back to, that somebody else can actually perform this test again. It's not just you saying, okay, this person is oriented. You can give your score on the MMSE, and then somebody else can come behind you and do the exact same evaluation and be able to really document changes in their mental status. Okay, the Glasgow Coma Scale. This is going to be another one that we do a lot with patients. Okay, we need to be very familiar with this. Glasgow Coma Scale is a quantitative tool. Okay, we're looking at eye opening. So we're looking at this patient. Is it spontaneous? So when you walk in the room, did they just open their eyes? Did you have to talk to them loudly? Or did you have to poke them painfully? I'm not meaning we're going to poke them, we're going to stab them with something, but sometimes you'll use the end of a paper clip. Or did they not respond at all? And then verbal response. What are they? Are they oriented? Do you consider them oriented? Are they confused, a little disoriented? Are they using inappropriate words? If they're talking to you and maybe they're talking about their dog, and they're calling it a barbecue sandwich or something like that. Incomprehensible sounds, and then they'll have none there. Then motor response. Do they obey? Do you tell them pick up your right arm and they obey? Can they localize the motor response? Do they withdraw from you? Is there flexion or posturing? Is there extension posturing? Okay. Or none of this. Okay. And see, look, we can have a fully alert score is 15. They can be in a coma with a 7 or less. And somebody who can be dead and have a 3. Nobody's going to have a 0 on this, okay? You can be dead and have a 3 on the Glasgow Coma Scale. Okay, so motor responses. We're going to check this by observation. What their muscle tone appears to be. Muscle strength. We'll have them squeeze our hands, both hands at the same time. Squeeze our hands. Push against our hands. Pronate or drift. We're going to have them hold their hands up like the picture of this boy. And we're going to have them hold their hands up and see if one arm drifts down. Give me 1 second.